Hello, my name is Marcel Miu, PGY1 at DMC Huron Valley Sinai Hospital, and today I am discussing our project Tablo, Optimizing Continuous Renal Replacement Therapy in the Community Hospital ICU. All of the authors involved in the study are listed below, as well as the attending staff member who oversaw the project. The hospital affiliated was DMC Huron Valley Sinai Hospital. Background on our study. Oftentimes, when patients are admitted to the ICU, they require multiple life-sustaining modalities, one being renal replacement. For that, it becomes crucial that not only different modalities become readily available, but also that they should be simple to use, highly effective, and most importantly, safe for the patient. Traditional methods such as hemodialysis and peritoneal dialysis are effective, but require closer observation by highly skilled practitioners that may not be readily available. This leads to delays in initiation, increased costs, and negatively affecting patient satisfaction and outcomes. Tablo, a relatively new innovative method of dialysis, has helped overcome the obstacles that come with traditional dialysis. It was designed to consider the patient's experience and can be used both in inpatient and outpatient settings while still being cost efficient. At DMC Huron Valley Sinai Hospital, Tablo is used predominantly in the ICU for patients where there are no barriers to conventional dialysis, and it is well liked by patients, physicians, and nurses. However, there are barriers to the optimization and use of Tablo. The purpose of the study is to analyze efficacy and application of Tablo in the ICU setting at Huron Valley Sinai Hospital and where there are areas for improvement. The study itself is a prospective observational study to identify ICU patients that had initiation of continuous renal replacement using Tablo. Data was collected between August and December of 2023. The patient demographics were ages 18 years and older who had been admitted to the ICU and were started on renal replacement therapy using Tablo. The managing provider of the patient would fill out a post-therapy checklist designed to document and track the experience as well as what worked and what could be improved on. The checklist also included patient's demographics as well as pre and post vitals, length of treatment, and any concerns or problems that arise. The project was brought forth and operated by the internal medicine residents in the ICU attending. The results of our study showed that of the 12 patients that were evaluated post-Tablo use, their indications were acute kidney injury, 8 of the 12, acidosis, 3 of the 12, and uremia, 1 of the 12. The majority of the patients were male, and the mean age was 66.3. The most common problems that arise were hypotension, in which cessation of treatment did occur, even if the patient was on pressors. Additionally, clotting in the dialysis lines occurred 5 of the 12 sessions observed. The mean time of therapy was 6 hours, and other issues that arise were nursing staff availability, user errors, and technical issues. Moving on to a discussion, Tablo is a form of renal replacement therapy that offers slow fluid and electrolyte exchange over a prolonged time with superiority for metabolic clearance, volume control, and hemodynamic stability. Complications include bleeding, thrombosis, hemodynamic instability, anaphylaxis, volume removal errors, and electrolyte disturbances. Our study showed that hemodynamic instability, mainly hypotension, was the most common complication and likely attributed to the inappropriate patient selection and/or user education and experience. A pitfall of Tablo is that it does not have a heparin pump, and critically ill patients have increased clotting risks due to elevated stasis, cytokine release, and clotting factors. Improved user education may be required to monitor for early clotting and to implement saline and heparin or regional citrate frequently to clear the cartridges and thereby reduce bleeding, improve efficacy, and lower costs. In addition, the utility of Tablo in unstable patients may precipitate circulatory collapse and premature discontinuation of therapy, which may be avoided by lowering the rate of fluid removed. Conservative patient selection may help to improve patient tolerance and success of treatment. Our results reflected common areas of complications known to this modality, despite the small population size. In conclusion, Tablo is a patient-centric form of renal replacement therapy that is designed to provide effective dialysis in a form of slower exchange that allows for an improved patient experience. There are several advantages over traditional dialysis, including its use in different settings, cost effectiveness, and tolerability. However, there are also identifiable and consistent pitfalls with Tablo that affects its ability to maximize use. Hypotension was the #1 reason for discontinuation of Tablo. One way to overcome this would be to have built-in pressure sensors that identify the patient of anticipated drops in blood pressure. This will allow them to intervene faster and allow for continuation of the session. The second reason for discontinuation was blood clots in the Tablo lines. One way around this is a heparin pump built into the Tablo machine that would allow for less time spent by the user needing to flush the lines with saline and heparin. Key areas that need to see improvement with efficacy for Tablo are technical upgrades, user education, and patient selection. Although data is limited with low number of patient sample size, this allows for a foundational aspect to future studies. Thank you for your time.